talking hormones and all things important to us as women's doctors, as doctors for women, kind of in 2024 as it relates to hormones. It's a huge topic, so we're not going to cover all the things, but we're going to kind of take a big dive because it is hormone month for us, and Kara's got a great story of why this matters.
We are here because we are failing healthcare for women, especially middle-aged women. I would say we're failing women across the lifespan. But we're really here to say there's a better way to do this, and we have the data. This is not known. It's just not being done. So the data is there. We're going to use the data and we're going to work on our hormone systems. And that's what Hillary and I want to do in the middle of our lives. We happen to be in the middle of our lives, and I know a bunch of you are too. So I recently went for my annual. And I didn't have my regular gynecologist. I just was like, sure, I'll go to the nurse practitioner. I don't really care, whatever. I'll just get this done at a time I can do it. Convenience was a factor in this decision. So I went in and I just asked some questions, and I want to report what was told to me. So I first started by saying, I have severe osteoporosis in my family, and I'm absolutely going on hormones. There's not a question that I am going on hormones. So I started to talk to her about this, and I got the worst quality care you've just ever heard of. And so the woman doesn't know me. I tried to, be really patient and kind and kind of see where she's coming from. But as a woman in there, like I'm in my mid 40s, I still do have a cycle. She wanted to first say to me, well, you still have a cycle. You have to wait for 12 months when you are totally done till you're in menopause, till we can give you hormones. So that was the first. And I was like, well, that's not true. And I was really being kind. I was not trying to jump down this woman's throat in any way. I was not, believe me, she's about to do a pap on me. I'm like going to be really nice. I was being really nice, I swear. And then I was like, well, I am having symptoms. And she's like, oh, you're having symptoms? I'm like, yes, I'm having symptoms. I'm having hot flashes. They start in my head. They go all the way down. I'm like skipping cycles. I'm maybe not as sharp as I used to be, which I don't really want to admit, but that's true. I can't remember things. I leave my cell phone everywhere. My cell phone is like constantly missing, and I'm having sleep problems. So between all of these things and the family history of osteoporosis, which she told me we don't give hormones for family histories of osteoporosis. So then I'm symptomatic, and she starts listening to me. I'm like, okay, great. Like, what do you have for me? Hillary, this is where it went really downhill. She wants to give me antidepressants.
In 2024.
Yeah. So I'm like, yeah, no, can't take antidepressants because guess what? I did a genetic test and it said you're not a candidate for antidepressants. They won't work for you and they will likely make you feel badly. So I was like, and that did happen to a family member of mine. So I know I can't take antidepressants. So then she bounces to gabapentin. I'm like, lady, I just told you that I don't feel as sharp. I want to be sharp. I take care of people for my job. I didn't tell her I was a doctor. I take care of people for my job. Like I can't be like dull. And I think gabapentin might make my brain a little dull. So I kind of thinking that's not what I want. Finally, she comes to the conclusion that she can give me the pill. And I say, well, I'm trying to bypass the liver detox system, which we're totally going to get into. The pill is not the only hormone, people. That's not the only hormone option. And the pill has always made me feel really sick in my life, really, really sick. So I don't do well on the pill. I'm one of those folks, and I have a reason why, and we're going to get into this over the next few days. So those were her options. Finally, when I say I don't do well on the pill, I don't want to go on the pill, she says, okay, you're going to have to go see one of the doctors. I'm like, why didn't you just say this to me in the beginning of this discussion? So anyway, I have to go to a different kind of doctor than just my regular annual visit to get what I want, which I was asking for a patch. And she could not do it. She didn't know anything about it. And instead of saying, this isn't my area, I don't know a lot about this, you should go to the person who actually prescribes hormones to middle-aged women, she was just going to put me on antidepressants. I would have walked out of there on antidepressants if I did not do this for a living.
So it's a really great time because there's so much going on about, it's like the time where women are taking their power back. Well, not in all ways, but in at least perimenopausal and menopausal women are getting the memo that we've been underserved with hormones, and that we don't have to fear hormones that we make ourselves. That if it is a kind of God created human body part of our existence from the time that we are born for several of these hormones, and then post puberty for others, that these are medicines, potent therapeutics that we can use as we're aging. So that's the good news about 2024. And what we're going to spend a little time deep diving into over the next several days and later in the month is talking about what Kara was alluding to, how we can support hormones as they're declining, as we have age-related hormone change, which is a normal part of our aging. And many people will say, well, isn't it normal not to, that we lose our hormones? And the difference that we're looking at now than compared to 100 years ago is we just live a really, really long time. And we've learned a lot about things that impact women, like osteoporosis, like dementia. If you hit our brain health series, you learned probably a lot about that are very, very hormone driven. Those are our hormones protect us against those things. So if we're walking on the planet for 90 years, we best not have 40 of those years where we don't have our protective mechanisms. And thyroid and cortisol are always in the mix, in the background. The thyroid and the adrenal glands, they sit on top of the kidneys, make cortisol. These are hormones that our body makes all the way through. And then our ovary produces estrogen, progesterone through ovulation, and testosterone in general. Those are kind of the main things. As the lights dim on the ovaries, as you're in for Kara, your late 40s, or you're in your 50s and you're going into menopause, you're going to notice a ton of changes. And we're here to speak about those changes. So one of the ways, let's just talk about like what I would have done differently if I was Kara's provider. Okay. So I would have been listening for keywords like family history of osteoporosis is wildly important to doctors like us, because osteoporosis, it's not a sexy thing to think about when you're in your mid 40s or late 40s, but it is something that is devastating for women. It totally changes their life, and it impacts their mobility, their ability to live alone, function, and any kind of fracture is a massive mortality risk factor. And nobody wants to be, the kyphotic woman is kind of the thing we think about. That's really late stage osteoporosis. Before that, it's small fractures of wrists. It makes it so we're not as stable in exercise classes. And many of us in our age band, if we were on hormones, if we were on birth control in our 20s and 30s, we're at significant risk for osteoporosis because our estrogen was suppressed over our lifetime. So I would ask that. I would have asked, how are you sleeping? How are you handling stress in your life? Like, are you able to handle as many things coming at you? And her answer would have been no. And that's what she was trying to get at when she was saying, my mind's not quite as sharp as it used to be. The way it presents for many women is like they can't handle things, like we're less resourced, we're less resilient. And that's what happens when our hormones that prop us up and get us kind of moving through the world go down. And then I would have asked, okay, well, how do you feel? Like, how's your vaginal health? How's your sex life? Are you enjoying your life? Are you having fun? Because I know that I can prescribe hormones to a woman way before she's in menopause. And that's fully driven by the data because she's still hormonal. Like, our estrogen goes up and down every month, and it has a very wide range. Our progesterone goes up and down in the later month, and then our testosterone moves, our thyroid's pretty stable, our cortisol goes up and down every day. So these are things where there's like a lot of movement, and there's no reason why we can't support them and give a little boost to women who are struggling in their 40s. So let's talk a little bit about testing, because I think that's a great setup, and just how the hormones work. And if you go in and are trying to get like, so one thing Kara could have said from the provider is, okay, well, how about if you just test my hormones? And she would go, no, we don't need to, test. The common thing is what is said is testing hormones doesn't make any sense because they change all the time, which is true on one level. But when you're the provider reading the testing data, you can understand that, like, somebody like Kara, if I know Kara's history, that she was estrogen dominant and she had endometriosis, she sure as shit better have a pretty high estradiol on her day 3. And if she doesn't, then that tells me that she's had less than she's used to, and any difference from what she's used to in her 30s into her 40s is going to put her at risk for all the things that we were just talking about, and just generally not feeling as resourced.
Mm-hmm.
So one place you could start with your providers, if they're trying to give you antidepressants or put you on the pill, is just say, well, why don't we just test to see where my hormones are?
Mm-hmm.
And
I will tell you that I recently had a patient that did that, took my test to the provider, just had a visit and was like, oh, these are my most recent labs. And they were like, yeah, we don't really care what the FSH is or whatever. We don't use that. We just go by the 12 months since your last menstrual period. This is
Kara's
really interesting.
Kara's in
Yeah, so we don't agree with this. Just get the lab test and then we have something to jump off of, right? We're data driven. We want to know what the lab tests say. So we want to make sure that everybody leaves today knowing when those labs should be done, because it's very often that women go and ask for lab testing and their doctors don't do this often. So they just have them go and it's the wrong day of your menstrual cycle. So your menstrual cycle, you're still cycling, you should know when to go get those tested. So let's go through that. So day 2 or 3 of your menstrual cycle is day 1 is when you have a period. And it can be just a brief little spot if you're perimenopausal. It could be any spotting whatsoever. It counts as day 1. And you might have your period 2 weeks later. And you might not have had it for 6 months. It doesn't really matter. Any spotting counts as a period if you're in this perimenopausal time. So you will go day 2 or 3 to the lab for follicle stimulating hormone that comes from your brain. It's called FSH and estradiol.
FSH is how we diagnose if a woman is still fertile. So when we get 2 readings of an FSH above 30, she's basically no longer fertile. So a lot of times people will be tracking this for, and if you're one of our patients, we're tracking it to get women when we know when they no longer need a form of birth control or protection to get pregnant. Because one of the other things that can happen in perimenopause is things are very odd timed, like Kara said. So late stage pregnancies can happen. And so, especially if you're working with a doctor like us and you're getting healthier and things get better, you can drop an egg. And we want to make sure that you're protected if a pregnancy is what you're trying to avoid. And so we're using FSH to see when you're pregnant. And that happens, like Kara said, in day 2 or day 3. And then estrogen, that's a really great time to look at how's the peak of estrogen starting, and is estrogen rising strongly? And if a woman is on the very low end of the range, we have a sense of like, okay, her estrogen might be a little bit lower than it was, again, when she was in her 30s, which is to be expected, and she might not be ovulating. Progesterone comes after a woman ovulates because the actual corpus luteum is responsible for making the majority of the progesterone. That's happening in after ovulatory time. So in a regular cycle, if a woman's having a 28-day cycle, that's generally around day 14. Obviously, there's a lot of factors that change a menstrual cycle.
Mhm.
And then after that, you're going to start to see the progesterone rise. So if it's a regular 28-day cycle, we generally test progesterone on day 19. So
There, sorry, Hill, I think you misspoke just as you were going fast there about the FSH. It's not a pregnancy number. It's a number that your brain is sending this hormone, follicle stimulating hormone, to your ovaries saying, get going, ovaries. It gets higher as your ovaries are not functioning as much. It's saying, get going, get going. The number's going higher, higher, higher because your brain's yelling at your ovaries. And that is meaning that it's harder for you to get pregnant. It is not a measure in pregnancy that we do. People are just asking questions. And I love how many of you have written in like, yeah, I was put on gabapentin, I was put on antidepressants, and that's why you're here. So we're gonna try and make it so that you have good questions to ask and better information.
we have a couple different audiences. So if you're on a fertility journey and you've had an FSH above 30, it doesn't mean it's fixed. If you're 50 and you're not on a fertility journey and my FSH is 35, I'm sort of officially like my ovaries are no longer shutting down. So
Or they
FSH
are
is
shutting
the
down.
way that we diagnose menopause in later years. The
Mhm.
official diagnosis of menopause is what Kara was alluding to before, that you've gone a year with no menstrual bleeding. But the really interesting thing is there are some women, and Kara could be one of those women because she was so estrogen dominant to begin with, that still fully cycle, even though they're not really going to get pregnant. So perimenopause is a really tricky time. It's very nuanced and it's very individual. And it
Mhm.
changes all the time with our stress. And Kara and I will say, like, if we're working with a 45-year-old woman that's trying to get pregnant and her FSH is high, and we're like, oof, we really need to rehab her ovaries.
Mhm.
Sometimes we rehab her ovaries and her FSH comes down and her cycle's healing. And
It's
that's her goal
amazing.
because she wants to get
It's
pregnant. Generally, like a 49-year-old or a 50-year-old, you know, we're generally they're on their way out. And so we're using that as a guide, as like, oh, you're super far from being in your menopause and you can still get pregnant. It would be a major oops and a rare thing, but it could happen. Or you're like into it. Okay.
So
We don't.
you are individual people and you're writing in these beautiful things. And I love this from Megan, that this is a knowledge fire hose. Thank you. So we'll stop with the details, but what we want to say is that you're individual human beings. So, and you're all important. So I think getting the basic numbers is a really good place to start, even if your doctor doesn't know how to use those numbers in clinical practice. Remember, Hillary and I do preventative medicine. We're always thinking 10, 20 years ahead, 30 years ahead. What's going on with this person? What can we do to impact their lives, to have them have a better life? That's what we do. So it's not just put them on some med to like band-aid some symptoms. We want to really have an effect long-term for brain health, for all kinds of things, and not just bones that I mentioned. So tomorrow we're going to get into progesterone. Make sure you come back tomorrow for the
Okay,
progesterone
wait.
talk. It's
Sorry.
important.
There's two things that I like to talk about, though, that when you're getting testing done, as you're going through menopausal changes that you're requesting, most doctors are on top of it, but you always want to track your TSH and hopefully a T4 and maybe a T3. Most medical doctors won't order a T3. Certainly Kaiser doesn't order T3s.
She
But if
can't stop the fire hose.
well, we have a few more minutes and I'm here to talk about it. So this is if a woman's going in, like Kara was talking about with her doctor, we want to know that the thyroid functions good to go. And you want to be tracking it because as the ovary changes, the thyroid can change. And that's a really important thing to track. The other thing that we track that many of your doctors might never order is cortisol. Cortisol can be tested. And it's a great way to kind of look at adrenal health. So again, if Kara asked the nurse practitioner, okay, I want you to test my this, she
I
would
don't think that was
probably
going to go well.
have said no. But we think it's one of those important things for you guys to just hear and understand. No one needs hormone testing. that nurse practitioner could have said to Kara, okay, well, why don't you try a low dose estrogen patch and some oral progesterone in the luteal phase? That would have been a really safe way to start. She didn't need hormone testing for that. You don't need testing in order to initiate treatment. You don't need to, that's not the standard of care, but like we're always interested in what's going on and how are things happening. So just there's obviously you go online on Instagram now. If you're on your phone, you've heard so many things that if you're on Instagram, you're just going to be getting inundated with menopause supplements and talks now. There's so much information online. We just want to say that your hormones are changing. They can be fully supported before you're in menopause, and they should be supported for most women before you're in menopause. Testosterone, we're going to get into later in the week. Progesterone, Kara said we're really going to focus on tomorrow because that's the first thing that changes in perimenopause. And so, and then estrogen, we're going to kind of deep dive into these things as the days go on. But just know that, this is the great thing is that we get to support our bodies and feel really, really good for lots of years. Kara's like obviously ready for me to stop talking. So signing off now. I get really excited. Tomorrow we'll deep dive into progesterone and ways that you can support it naturally and using the hormone if you choose.
I